Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Economic Burden of Chronic Lymphocytic Leukemia in the Era of Oral Targeted Therapies in the United States, by Qiushi Chen and colleagues. My name is Dr. Christopher Flowers, and I am an Associate Professor at the Winship Cancer Institute and the Department of Hematology and Oncology at Emory University in Atlanta, Georgia. My oncologic specialty is in hematological malignancies and stem cell transplantation. In a study led by Dr. Lauren Terrace, we recently provided estimates of the total numbers of U.S. lymphoid neoplasms by World Health Organization subtype, as well as a detailed evaluation of the incidence and survival statistics. In 2016, 136,960 new lymphoid neoplasms are expected, making lymphoid neoplasms the fourth most common cancer and the sixth leading cause of cancer death in the United States. 20,980 patients are expected to be diagnosed with chronic lymphocytic leukemia in the United States in 2016, with survival rates that vary by race and gender. 5-year survival rates are 70 to 80% for patients with CLL, and 10-year survival rates are 66% for white females and only 39% for black males. Despite these disparities, the care of patients with hematological malignancies and chronic leukemias in particular has been dramatically altered over the last decade by the development, approval, and broad utilization of oral targeted agents. In the article that accompanies this podcast, Qiushi Chen and colleagues examine the potential impact of oral targeted therapies for the treatment of patients with CLL on the cost of care for individual patients and from the societal perspective. Chemoimmunotherapy regimens such as fludarabine, cyclophosphamide, and rituximab, FCR, bendamustine and rituximab, and chlorambucil and rituximab have been the standard first-line treatment for patients with CLL. In the last few years, an improved understanding of the biology of CLL has led to significant advances in the treatment of CLL and the development of oral targeted agents such as ibrutinib, idelalisib, and venetoclax. In the relapse setting, the PI3 kinase inhibitor idelalisib, in combination with rituximab, significantly improved rates of overall response, 81% versus 13%, and overall survival at 12 months, 92% versus 80%, when compared with rituximab alone. In a series of trials, the Bruton's tyrosine kinase inhibitor ibrutinib produced a progression-free survival rate of 75% and an overall survival rate of 83% at 26 months, and significantly improved overall survival, progression-free survival, and overall response rate, 43% versus 4%, in comparisons with ofatumumab. In a series of trials, the Bruton's tyrosine kinase inhibitor ibrutinib produced a progression-free survival rate of 75% and an overall survival rate of 83% at 26 months, and significantly improved overall survival, progression-free survival, and overall response rate, 43% versus 4% in comparison with ofatumumab in the relapse setting. In a phase 3 study in previously untreated older patients with CLL, ibrutinib significantly improved response rate, progression-free survival, and overall survival in comparison with chlorambucil. At 24 months, overall survival was 98% with ibrutinib versus 85% with chlorambucil. In another study, the oral BCL2 inhibitor venetoclax was evaluated in CLL patients with deletion 17p, a poor risk subgroup, and produced an overall response rate of 71%, with 16% of patients experiencing complete response. In 2014, the Food and Drug Administration approved ibrutinib for patients with relapsed and refractory CLL and for patients with deletion 17p, and idelalisib in combination with rituximab for patients with relapsed refractory CLL. In March 2016, ibrutinib was approved for first-line management of CLL, and in April 2016, venetoclax was approved for patients with relapsed CLL with 17p deletion. Other PI3 kinase inhibitors such as duvelisib and TG1202 and BTK inhibitors such as acalabrutinib and numerous other targeted therapies have completed phase 1 evaluations in CLL. Together, these agents and approaches to disease management are expected to change the outcomes and the cost of care for individuals with CLL and for this population within society, since the cost of therapy with these agents can be greater than $100,000 per year, and patients are planned to continue these therapies until disease progression. Chen and colleagues developed a microsimulation model of CLL management that simulated the dynamics of this patient population under specific management strategies in the United States from 2011 to 2025. Microsimulation is a modeling technique that uses a large sample size of individual units, referred to as micros. In this model, each individual patient with CLL is a modeled unit. Each individual in the model can have a unique set of attributes. The model allows simulation of downstream events based on predefined states and assigned probabilities of transitioning between those states over time. In each state, a patient can accumulate benefits such as improved survival, negative effects such as adverse events, and costs. Microsimulation modeling is particularly useful in studying optimal intervention strategies where randomized controlled trials may not be feasible or practical. Dynamic microsimulation, when used in medicine, is particularly powerful as it retains memory of prior behaviors and states and allows a more explicit representation and understanding of how various processes over time affect the total aggregate of outcomes for a population. In the last 2 decades, large microsimulation model initiatives in Canada and the United States have changed the landscape of informing clinical guidelines and health policies. In this model, patient characteristics were defined by age, phase of CLL treatment, such as watchful waiting, first line, or relapse, as well as deletion 17p status. The age at diagnosis for each individual patient in the model was sampled from the age distribution based on the National Surveillance Epidemiology and End Results data. New CLL cases were added to the simulated population each year based on the published annual incidence estimates from the American Cancer Society. The prevalence of CLL from the simulation model was calibrated to match SEER data. The probabilities of health state transitions in the simulated clinical pathways were estimated based on the time to treatment, progression-free survival, and overall survival data observed in clinical trials. Direct medical costs were considered, including the cost of drugs and administration, the cost of routine follow-up, and the cost of management of adverse events. The likelihood of common serious adverse events was simulated based on the reported incidence in clinical trials for each therapy. Based on these inputs, the simulation model projected the number of people living with CLL and the annual cost of CLL management in the U.S. from 2011 to 2025. Based on these inputs, the simulation model projected the number of people living with CLL and the annual cost of CLL management in the U.S. from 2011 to 2025. 2 important model outcomes were the projected lifetime out-of-pocket cost of the oral targeted therapies for patients enrolled in Medicare Part D plans, since many CLL patients are Medicare eligible at the time of diagnosis, and the incremental cost-effectiveness of oral targeted therapies in comparison with chemoimmunotherapy. This study projected that the number of people living with CLL in the U.S. will be about 199,000 by 2025, a 55% increase over 2011 figures due to the improved survival associated with new therapies, and projected that the annual cost of CLL management will increase from $0.74 billion to $5.13 billion, a 590% increase over this time period. The simulation model projected that as oral targeted therapies transition to become the standard first-line therapy, the per-patient lifetime cost of CLL treatment will increase from $147,000 to $604,000 for patients enrolled in Medicare. the total out-of-pocket cost will increase from $9,200 to $57,000. Compared with chemoimmunotherapy, oral targeted therapies resulted in an incremental cost-effectiveness ratio of $189,000 per quality-adjusted life year, suggesting that the increased benefit and cost of oral targeted therapies may substantially enhance CLL survivorship, but can impose a substantial financial burden on both patients and payers. Existing and emerging therapies in CLL and other lymphoid malignancies dramatically improve disease-free and overall survival for patients, which needs to remain the highest priority in clinical research. However, as this simulation modeling study points out, these additional benefits can come with substantial increases in the cost of care for patients and society. Additional efforts are necessary to address the pricing structure of medications and the selection of management strategies when therapeutic alternatives exist to address these issues. Modeling studies like the one presented by Qiushi Chen and colleagues can project where these needs and opportunities exist and empower future investigators, payers, and policymakers to develop approaches that address these challenges. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.